Now it's good. Okay, thanks a lot. All right, we're going to talk a little bit today about oral assessment in aging, and I think it's important to realize that oral assessment is an area that has been ignored for a long time, and why that has occurred. And there are basically two reasons. One is because when Flexner did his report in the early 1900s and looked at medicine, and we began to have the exams and requirements for school training and no longer having the ability to apprentice, right after the Flex exam came into being, they had another Flexner report, and what he did was examine dentistry. And at that time, he told dentistry, you have an opportunity here to make a decision. You can go along the way the Europeans have done this, and the Russians and the Easterners, and stay with medicine and become a subspecialty, or you can separate out and become a different discipline entirely. And at that time, we had people who didn't live to be very old, and if they did live to be old, they had no teeth. So it became an issue where you didn't really need to know a lot of medicine at that time to be a dentist. So they separated the two disciplines. And what happened when we had the separation is that dentistry lost a lot of its information about medicine, and medicine has lost its oral medicine as a result. And what we're going to do today is attempt to put a little bit of the two together again and give you some reasons, and particularly now that our older patients continue to have oral problems and they are not losing their teeth anymore. So that means we have issues of analgesia, anesthesia, antibiotics, anxiolytics, etc., that all come into play with dental treatment that were not such an issue 50 or 75 years ago. Another important reason for looking and doing an oral assessment is because we have so many patients, particularly institutionalized patients, who develop oral problems that can have serious systemic sequelae. And there have been cases, particularly in nursing home residents, of oral infections going on to cerebral abscess, and everyone, of course, is aware of the risk, though it has not shown to be extreme, for bacterial endocarditis. Osteomyelitis is a problem, and septicemia is actually a larger problem, and of those four, quite often presents itself as the very largest. As you know, there's new literature that's coming out now and studies that are being conducted looking at the notion of periodontal disease seeding not just heart valves, but actual bacterial plaques in coronary arteries that are developing because they've done some looking at those plaques and found oral bacteria in them. And there was another study more recently looking at the issue of stroke and periodontal disease. So it becomes, again, another good reason to correct problems that are there. And because so many of the patients that we see are institutionalized, we really want to be careful about this with all the stroke patients, the Alzheimer's patients, other folks that have problems with aphasia. They can't express whether they're in oral pain, and quite often can be uncooperative in letting someone actually examine them. And if they have a serious problem, it goes undiagnosed. I think one of the issues that we see tremendous neglect in elderly patients, whether they're confined at home or in other institutional settings, is that they have other problems. And one of the things that happened in the 60s when we had Medicare and Medicaid come into effect was that organized dentistry fought very hard to keep dentistry out of Medicare and Medicaid, so that it is still largely for the elderly an out-of-pocket expense. Therefore, it comes after medicine, after food, after a lot of other areas that are much more important to them. In addition, now, because dentistry had been so separate from medicine for so long, we have dentists who are very uncomfortable with treating medically compromised elderly patients. So we are trying to sort of meet that need at the same time as the demand is beginning to increase for the need for care for these individuals. And the last issue that comes into play is the fact that a lot of dentists simply do not have the equipment necessary to go into a nursing home and treat patients on site. And certainly when it comes to the issue of Alzheimer's patients or other dementia patients, you really would want to treat them on site because their behavior is so much better in familiar surroundings. What's happening now because of OBRA 87 is that in 1990 we had the dental portion of the law go into effect, and everyone who works with nursing home residents is aware of, in those facilities that accept Medicare or Medicaid dollars, the need for the minimum data set or minimum data set plus to be filled out on every resident or new resident within the first 2 weeks. And now these things actually include oral screening, sections L and M particularly. What we found in interviewing a lot of nurses in one study that we did nationally was that nursing was extremely uncomfortable with having their names put on these forms as knowing what it is they're looking at dentally when they haven't had adequate training. So another area we're trying to do is train nurses to be more comfortable with this screening, and also to invite dental practitioners to go in and contract with facilities to be attending dentists, do these exams for free and prepare treatment plans that would at least give a start to identifying what the needs are and how great they are. Particularly soft tissue lesions, whether they're a result of irritant, whether we pick up oral cancer, not just periodontal disease, and other sorts of lesions, and I'll be showing you a few of those. And of course, periodontal disease, caries, and prosthodontic needs. Hopefully, what this will all result in is improved access to care for these nursing home and other confined elderly. The Texas Dental Association, the American Dental Association, and the American Society for Geriatric Dentistry have come out with policy statements saying that they really feel that not only should these exams be conducted after the assessment is done, within something like 30 to 45 days after the minimum data set is completed, but annually thereafter, and that we need to work actively with relationships, building relationships between the dental providers in the community and nursing facilities. And that in lieu of the availability of equipment, that those residents who can be transported should be transported to the dental office where oxygen is available and other emergency management if necessary. I just wanted to show you Section L to remind you about Section L as the oral nutritional status. And this is question number 3, where if someone is dehydrated and is complaining about the taste of many foods, these things can be clues not only for issues related to medications, but there may be something dental going on. If someone has an oral infection, it's going to affect the taste of the food. The next one is question 4, where we look at what's happening with the actual diet. And if you look at 4C, it says mechanically altered diet. Anyone who has a mechanically altered diet usually has some sort of dentition difficulty, whether they're a denture that's present or not present, or whether there are missing teeth, what have you, in addition to other constraints that may be related to gastritis. And certainly if someone in item G is using a plate guard or a stabilized build-up utensil, that individual should also have some sort of aid attached to a toothbrush if they're doing their own oral hygiene, or it's not going to happen. And ideally we want as much independence for these people for their self-care as possible, because the nursing staff is overworked, and we know that one of our primary problems in nursing facilities is that nursing aides do not look in the mouths or clean the teeth. It's very, very rare when this is done. And we look in the records and we see there on the form that all the medications were given, and it's checked off and initialed religiously every day, as is the part that says, yes, and we cleaned their teeth. But if you looked in the mouth, you'd readily see that, of course, that had not been done. So if there's some way to get patients or their family members interested in doing this on their own, then we ought to try to pursue it. And lastly, Section M, the actual oral nutritional status, where we're looking at question 1, which really relates to the oral disease. We're looking for plaque in item A, debris, anything that is there at bedtime. If they have dentures or some sort of partial denture, which is a removable bridge, that was going to need its own type of cleaning. And if they're missing any teeth, if they have broken, loose, or carious teeth, and if they have some sort of periodontal disease or abscess or ulcer or rashes. And that indeed these people need to have their dentures and teeth, when dentures aren't present, cleaned every day. For the minimum data set, we have a number of sections of the minimum data set that can be confounders for what's going on orally, and I just wanted to mention that, and that would be of interest to any nurses who are filling out the form. So the kinds of things that you look for, particularly in cognitively impaired patients, that clue you in that perhaps there's some sort of oral problem, can be anything from altered taste to not eating and being hungry, or having sudden loss of appetite, which could be related to an oral infection, or simply not eating or drinking. And since we are going to be talking about the oral exam, the first thing to do is to wear gloves. This is herpetic whitlow, and there are some patients who have herpetic lesions that do not show up right away. They get prodromal herpes, where the virus is actually on the skin, and you can pick it up if you have a cut in your finger. So it's vitally important to wear gloves. This is lichen planus, and lichen planus is usually a systemic, as you know, condition. And here we have a classic picture of what it looks like intraorally, and it is extremely painful. And it is right out of the textbook kind of shot here with the butterfly-shaped lesion and the white striae or striae, depending on where you were taught, around it. And that is a classic view, but we don't see that very often. We're more likely to see lichen planus in this more subtle form. And when we do see it, it does need to be treated. And obviously steroids are the treatment of choice. And that does remind me that I wanted to let you know that there is an article in the handout that was given out that's called Oral Health Screening Guidelines for Non-Dental Healthcare Providers. Dr. Mobley, who will be talking next about nutrition, and I co-authored this one for the Journal of the American Dietetic Association when we were trying to get nutrition professionals interested in looking into mouths a little bit, because if you can't chew it, you won't eat it. And coming out very shortly in the Oxford textbook of geriatric medicine, it's due for release in the next few months. I have a chapter there that's on oral screening for physicians in geriatric patients. So with that in mind, let me briefly turn this lamp on over here. And if we could switch to that, that is the diagram in the article that you have as a handout, which is the chart for systematic oral screening. And basically this comes from NIH and is a lettered way to track yourself through the mouth so that you do it systematically and routinely every time you do it. And that's just for your guidance. And also for your information, I'll put this other one up. You didn't see it, you didn't get it. I'm so sorry. All right, well, I'm glad you told me. Okay, and that's okay, but because we can supplement it with the article. But those of you who have the article, and if you don't, just let Lily Terillian know, or your tech who's at the site, and that person will take your name and get it to us, and we'll make sure you get this. And it basically has A through, I believe, at the very least, VW, yes, A through W, where you're looking at everything from the lips to the tongue to the floor of the mouth and all of the soft tissue for that part of the exam. And lastly, you definitely do not have this one, and this is just for your information. And that is to let you know that every tooth in the mouth has a number. And there is a universal numbering system that starts with your upper right third molar and goes around the upper arch and then drops down to your lower left arch and then goes around to the lower right arch, so that you have, if you had third molars, 32 teeth, and they are numbered. And every tooth has a surface that is either mesial, distal, facial, or buccal, depending if it's at the cheek, lingual, if it's on the tongue side of the mouth, and that the chewing surface is occlusal, and the biting surface on the anteriors is incisal, and that's how we number those things. We have a course here every other year for the medical examiners and other interested individuals, some of them dental folks in forensics, and we've trained the medical examiners around the country now in the use of this chart. So there are a lot of physicians who are becoming familiar with the numbering system. Okay, we can leave this now and go back to the slides. And we see a lot of soft tissue lesions in older patients that have an emotional component. And oddly enough, one of them that we see often is benign mucous membrane pemphigoid. And this is an individual, you're looking at the lingual surface or the tongue surface of the lower anterior teeth. You can see that the biting surfaces have been very worn, and there are very wide tops to these teeth where normally there should be just a skinny edge, and that there's a lot of erosion and abrasion of the roots of these teeth. And this person has periodontal disease. There's indeed plaque present around the roots of the gum line. But the soft tissue that abuts the most posterior surface of these teeth, you can see is puffy, red, and the areas are clearly not normal. Tissue is supposed to be pink, not flaming red. This is a patient, and this one came into a clinic with this ulcer, and there are two most prominent places for oral cancer in the mouth. One is the posterolateral border of the tongue, which is where this is, and the other is the floor of the mouth. So when someone presents with something that looks like this, the first thought is, well, are we looking at something dangerous here? Are we looking at a traumatic lesion? And when they looked at the teeth opposing the tongue, they saw a lot of rough amalgam, broken tooth structure, and they decided this most likely was traumatic. So they gave the patient a little ointment to put on that, which was Kenalog and Orbase with a little steroid in it, and said, go away for about a week and come back and we'll look at this again. The patient came back a week later and it looked identical to this, and that made them very nervous. So they said, well, we probably ought to biopsy this. So they biopsied it to see what it was, and it came back as a traumatic lesion. However, the patient came back about 6 weeks after the biopsy, and this is what the tongue looked like. Now, why would it do that? Is that focused? Is that okay? All right. And this required some serious surgery to reduce this tongue and stitch this together. And the reason is that it's not just dentists and physicians and other healthcare practitioners that have separated out the mouth from the rest of the body. but so have the patients themselves. And this is a patient who came in, gave a cursory health history, and didn't let on that he had diabetes. And what you see here is what happens in a diabetic mouth when there's uncontrolled diabetes going on. So it becomes extremely important that all of this comes together. This condition, these are very, very sore, miserable feeling ulcers in the floor of the mouth. This is recurrent aphthous stomatitis. This has an emotional component as well. No one knows why people get these things. People sometimes call them canker sores, and it's hard to figure out whether they mean aphthous ulcers or herpes lesions, which would be usually on the lip. And when you get herpes orally, intraorally, it quite often will be on the gum. But floor of the mouth, cheek, very common sites for aphthous stomatitis ulcerations. Also the lip, the inside of the lip. This is the textbook candidiasis that we're taught to look at. It is not what we see very often unless we're looking in a very immunocompromised patient's mouth or an elderly patient who has had a denture that hasn't been out of the mouth for about 20 years. And when they take the denture out, all of this curd-like plaque comes off with it, and there's a lot of bleeding. And you can see this on the left rear of the slide, which corresponds to the posterior right side of the mouth, where it's very bloody looking. And there are a lot of ways that this can be prevented and certainly treated, but what you will usually see is just swollen and redness in the tissue of the palate and the alveolar ridges where the teeth used to be. This is an individual in a slide that's not very good, I'm afraid, who has practically no supporting bone structure left after loss of the teeth. This is also a patient who turned out to have anemia, and this was picked up because of the oral exam and not the medical one, because this person had not been to a physician very often, so was referred to a physician for treatment of the anemia. This is an individual who you look at and you start to worry and you think, gee, that's a leukoplakic lesion. Are we looking at oral cancer here? That's an unusual place for it. This was a person who had a toothache and was told to take some aspirin and call the next day, and what they did was take the aspirin and place it in the labial mucosal fold there and cause themselves a nice aspirin burn. This one looks a little bit similar, but it's on the floor of the mouth, and this one is squamous cell carcinoma. The problem with oral cancer is that it's one of the deadliest cancers, and if those of us who are not dentists look in mouths, we definitely need to look anterior to the pharynx and look at the posterolateral borders of the tongue by grabbing the tongue with gauze, extruding the tongue, and looking with some sort of point light source to see those areas, and the same with the floor of the mouth, looking at the floor of the mouth, because if these things go undiagnosed, they're very, very fatal, and they advance and metastasize very rapidly. We see a lot of patients who come in with some sort of actinic keratitis on the lip, and we're trying to encourage patients to use screens because they can avoid having this progress to needing lip shaves because of squamous cell in situ. And we've seen this do that. It begins to crust, and older patients with frail, thinner skin, it becomes an issue. This is a chronic ulcer, again, near the floor of the mouth, but you're not going to see oral cancer manifest itself with something that looks so beautifully circular. The margins on this are uneven towards the bottom of the slide, but very rounded towards the back, and oral cancer does not look like that. This is a chronic ulcer that was caused by a prosthesis that this patient had been wearing. This particular patient had what he thought was a denture ulcer, and he ignored it and ignored it and ignored it for about 6 months. when he finally knew, it certainly wasn't a denture ulcer. Most likely he had some sort of oral cancer. That's why we don't let denture ulcers go, because they're not always denture ulcers. They could be squamous cell carcinoma and look like this. You can imagine what his surgery looked like after this. And he actually lived 3 years. He had radiation. He had a surgery that left him with no bone from his maxillary ridge on that side all the way up to his orbit. And it was very difficult. We made him a prosthesis. We were able to make him a prosthesis. And you can do that and give someone a facial shape as long as there's a tuberosity, which is the area where your most posterior molars and your upper arch are. If you have one of those on one side of the mouth, you can have a prosthesis to fill in the gap, and these people do not have to look like they have caved-in faces. This individual is another person who had had oral cancer, and he has just completed his radiation therapy. Unfortunately, the dental folks did not see him before his radiation therapy started, so he began to develop radiation caries, and radiation caries, the teeth, when it advances far enough, will fracture at the gum line, and that's not a good thing, because we don't want to have to do extractions because of the risk of osteoradionecrosis in these individuals. We want to retain the teeth that we can retain before radiation therapy, remove what we have to before radiation therapy, and fix what we have to beforehand, and all we need is 2 weeks. If we get that 2 weeks, then people don't have to go through the kind of torture this man's going to undergo. We see a lot of basal cell carcinoma, as you can see, in this case, in a very edentulous patient. And the thing that keeps you having bone and face shape in your lower face is your teeth. And when the teeth go, the bone resorbs, and in this case, we've got the chin approximating the nose. So this is not just in cartoons, it actually does occur in real life. And this individual had basal cell. We also have come across individuals who have had basal cell reported and decided they were too afraid. All they know is the word cancer, a lot of older patients. And we have to be extremely careful when we come across cancer in older patients, how we break it to them, and to describe for them, especially if it's something like basal cell, that this is not invasive and that it's not a, unless of course it's erosive basal cell, which is rare, and that it's a very simple treatment and it's fine once we begin to take care of it. The next patient was a gentleman who was told he had basal cell cancer, and all he knew was that he had lost his wife and his mother to lung cancer and breast cancer 20 years earlier, and there was no way anybody was going to go and give him surgery and chemotherapy and radiation, and he didn't give anybody a chance to explain. And he disappeared into his trailer for about 10 years. And when I saw him, my medical consult from the folks was to dentistry, loose dentures. And you would think there was absolutely nothing we could do for this guy. Now, he came in with a severe Pseudomonas infection, and what you see here is his antibiotic and soothing ointments on his face to try and give him some relief. And he was just waiting to die, when everyone was hoping that he would have a nice electrolyte imbalance and go that way in a nice coma and not have his basal cell carcinoma erode his internal carotid arteries and then bleed to death, and that would not be good. And he was very lucky. He did actually eventually die from the electrolyte imbalance, but in the meantime he had 3 weeks. And in that 3-week period of time, we decided we would see if we could give him some quality of life. And what I rigged for him was a weird orthodontic headgear and some acrylic with a wing nut and a bolt and a real nice soft reline material, and he was able to eat his favorite, in addition to the syringe full of liquid they fed him with this, he could ingest his favorite candy in the whole world, which was liquid cherries. So he had about 3 weeks of that, before he couldn't do that any longer. And with this device in, he was also able to communicate with only one individual who could actually understand him. The rest of us could not. But the one nurse who could understand him worked when he was awake and went home when he was asleep, and stuck with him for those 3 weeks. So he had some quality of life and could communicate with people for those 3 weeks. We see a lot of folks who have 20-year-old dentures, and these are so old and have never been out of the mouth and never been cleaned, and they are so covered with plaque that is hardened into calculus that you can't even find the teeth on the dentures anymore. And you can imagine what the tissues look like. The candidiasis, the swelling underneath dentures like those. And briefly, so that we can have ourselves move along here to our next speaker, I just wanted to show you a few of the kinds of mouths we see that have teeth in them, whether they're, again, in institutionalized or homebound, medically compromised elderly. And you see a lot of periodontal abscesses, a lot of plaque that can cause the infections that go along with this that have not been maintained or cared for in any way. And when you've got, as you know, already a frail elder, they just simply do not have the reserve to take one more thing, and we certainly don't want them to have any oral infection, if we can avoid it, that becomes systemic. This is another one who had more teeth in terrible shape. Same story though, lots of swelling due to the periodontal disease, and most of this is periodontal disease and not carious lesions on the teeth. This is someone whose teeth were probably extremely loose, but they were bonded together so well by the calculus that they were sort of like a brick in the mouth, and they were actually functional. And we were really torn as to whether we were going to remove that and clean it up a little. And what we decided to do was actually raise the bottom of the calculus deposits up the tooth and keep them clean at the gum line so they wouldn't have any of the oral infection at the soft tissue, but they had the stability of essentially a splint to keep the teeth functional. Stroke patients present a unique problem because they develop something called affected side neglect. If they have a unilateral stroke and they're caring for their own mouths, they often forget the affected side from the stroke. It's uncomfortable for them, they forget it's there, they don't want to look at it, they don't want to deal with it, and they often forget. So we'll see half a clean mouth and then a mouth that looks like this on the other side quite often. And they just need to be reminded. They can often do a lot of self-cleaning, and I advise working with occupational therapy on this to devise straps, whether they're used like this on the palmar surface or the dorsal surface of the hand. And this particular patient had a number of problems that were both carious and periodontal in nature. You can't even see the caries, it's so full of plaque. And lastly, another patient with a combination of things. This is a patient that has dry mouth. We see dry mouth quite often in older patients from everything from the medications they take to systemic illnesses like systemic lupus erythematosus or diabetes as two examples, and rheumatoid. For some reason, these individuals also develop dry mouths. They get caries, and in this case, it was an individual who also ground his teeth quite a bit and lost a lot of the occlusal and incisal surfaces. So these are just a few examples to give you an overview of the kinds of things that you want to look for. I think the important thing that we want to do in looking at the oral problems that elderly patients have who are medically compromised is to focus on teamwork, that we're struggling very hard to educate and train our dental health practitioners to be more amenable to coming into all sorts of extended care facilities to do this treatment and to accept those folks as patients in their practices and to follow their patients as they go through all of the continuum of care as their own particular health declines in these patients. And if we can get those folks doing it more, then as the demand increases, the need has certainly been there forever, but the demand has not been addressed. And now the demand is increasing because of the law, and we just need to start meeting the demand. And that's going to mean, I believe, coming from our medical colleagues, orders for medically necessary dental care and having the nurses screen for those emergencies, especially the ones for the aphasic individual who can't describe their own pain and who may be in grave discomfort or have infections that need to be treated. So if we all work together, I think we can make some headway in preventing some of the systemic sequelae of these problems. Any questions? Any questions at any of the distance sites? Kerrville, Pan American, or West Texas A&M? No questions, okay. Thank you.